Welcome back to Talking About Glaucoma, a podcast of indeterminate length and frequency. I'm your host, Robert Schertzer, a glaucoma specialist from Vancouver, BC, Canada. To help produce future shows more frequently, I will no longer include artwork and chapter markings. Hopefully, this will get me back on track to publishing new episodes each month this coming year. As always, contact me at podcast@iguy.org, that's IGUY.org, if you have a glaucoma topic that you would like to discuss with me on a future episode. In this episode, I talked with Murray Johnstone from Seattle about pulsatile flow through the trabecular meshwork and collector channels. We discussed the imaging improvements over the years that have made this possible, including the latest phase-based OCT scans that result in nanometre resolution instead of the micrometre resolution of spectral domain scans that most of us are using in clinical practice. I'm Rob Schertzer, and we're talking about glaucoma.
Okay, well, welcome to the show, Murray Johnstone from Seattle. And today we're going to talk about pulsatile flow through the trabecular meshwork and collector channels, which is something that you've been working on for a few years. And it always amazes me, like the things you come up with. Really don't know where you pull these things from in your mind, what makes you think you dream these things up, but let's hear where this came from and its implications.
Yeah, what's interesting is it didn't just suddenly happen. Has been an evolution over many, many years. And I first started out, I worked in a aqueous outflow lab in Seattle many years before I even went into Morton Grant's lab at Howe Lab in Boston. And I learned a little bit about aqueous outflow and thought maybe I could make a contribution. So I went into his lab and realized I knew almost nothing, and started reading a great deal, and realized that the arachnoid villi, they discovered what looked like structures that were in very active motion, or little tubes that were opening and collapsing, and I began to wonder if there was a similar thing in the trabecular meshwork. And so I ended up doing a series of studies in living primates, actually, where I would fix the eyes at different pressures, and was able to come to realize that the trabecular meshwork really is in very active motion. And I was sort of stunned by it, and the concept that the giant vacuoles were actually just pressure-dependent structures, and that
was this whole eyes, or was this
perfusion whole eyes in
models?
vivo? Wow. When animals were alive still. So I had normal upscleral venous pressure. I could drop the pressure in the eye and reverse pressure gradients. So it allowed us to do a lot of things that had not been done before. And I saw what looked like a set of valves with structures that were spanning across Schlemm's canal, and I could basically get blood reflux into these things, but nothing came across Schlemm's canal endothelium, which made me think that they were acting as little valves. So over the years, this sort of haunted me, and I felt that I should try and explore it a little more and figure out what was going on. But I got busy in a clinical practice and really kind of put it aside for a number of years, but then came back to it with, I guess, maybe 10 or 15 years ago, I started working with Robert Stegman and asking him what he was seeing. And I kept reading about the aqueous veins and realized that aqueous undergoes pulsatile motion from Schlemm's canal into the aqueous veins, and something has to be pulsatile or pumping. There has to be some tissue motion for that to occur.
So this, he had that high speed,
he had a
high resolution,
extremely high resolution camera, right?
And you could see the pulsatile flow through the
right. Well, I saw it through the aqueous veins, and there was a great deal of documentation in the earlier literature when the golden age of clinical observation first became available, and really the slit lamp was a tool that was the technological breakthrough that allowed Asher and Goldmann to discover the aqueous veins and the pulsatile flow there. And as a result of that, first of all, they saw the flow in the eye or into the aqueous veins and discovered or made it definitive that aqueous was flowing, which is a fundamental thing that had not been established until that point. But the other thing was a highly salient feature was that the flow was pulsatile. And in their earliest papers, they pointed out that the aqueous outflow drugs were increasing the pulsatility. And that was a major clue that there's something about the pulsatile motion that increases in the context of pressure improvement with glaucoma medications.
So how would it increase the pulsatility? Is it altering the tissue?
Well, of course, the question was, why is it pulsatile flow altered? And they really didn't have any answers back then, but there were a number of studies with adrenergics and also with miotics showing that if you basically introduce these drugs into the eye in glaucoma patients, in patients who had very little or no pulsatile flow, dramatic increase in pulsatile flow within a matter of minutes, with adrenergics within 5 minutes, and with miotics within about 15 minutes. And actually atropine slowed pulsatile flow. So they had a whole series of basically pretty clear observations about what was happening, but no explanation of why. And I went back and read Goldmann's work. He thought that the meshwork was rigid, and they couldn't explain how the ocular pulse could get across the trabecular meshwork to Schlem's canal to drive the canal motion. And so through his entire career, he and Asher as well were never able to provide a synthesis of the fact that the aqueous outflow was pulsatile, that there was a pulsatile flow, of course, inside the eye, where we have typically about a 3 millimeter pulse variation. Right. So there was this situation that was there. And of course, the answer to this, as time has gone by and we've realized that there's motion in the trabecular meshwork tissues, that the pulsatile flow in the aqueous veins results from the ocular pulse, which drives the trabecular meshwork. It has got to be moving. It's the only explanation possible that permits an explanation for the driving of the ocular pulse to drive flow out of the eye.
So then those drugs that you mentioned would be parasympathetic or sympathetic stimulants, so they would alter the blood.
Exactly.
The blood flow.
Yes. So, well, of course, pilocarpine is well known to increase contractility, and of course, we have the work from Mike Van Buskirk and others showing that if you basically increase the tension, which is simulated with the lens depression experiments, if you increase tension on the ciliary body, what it does is makes the intratrabecular spaces enlarge. It causes the canal of Schlem's to enlarge, and it actually then puts the meshwork in a position to expand and basically undergo motion much more actively in response to pressure gradient changes. And particularly the ocular pulse. So it provides it now an explanation in retrospect, but not one that was apparent before. And the issue with adrenergics remains a bit of an unknown. It may be that there's a downstream improvement in basically reduction in resistance. There's considerable work now that, for instance, bromonidine reduces episcleral venous pressure, and that it may be that the whole apparatus can simply start moving more effectively when there's what they call the afterload is reduced in the system, sort of like in the heart when you reduce the afterload. So those are clues. And another thing when we started studying...
So when you have more motion, you have more aqueous flowing out through...
Exactly. You've got enhanced pulsatile flow. Okay. Yeah. Right. And it's literally a stroke volume, and a stroke volume that they characterized in lymphatics as well. The lymphatics are described as mini ventricles in the sense that when you've got the pulsatile changes within the tissue as a result of alterations in tissue turgor with changes in the cardiac pulse, what that does is drive these little mini ventricles each time to drive lymphatic fluid forward within the aqueous veins. And this same phenomenon presumably is occurring in the within the outflow system of the eye. So that's the conceptual framework, at least. And as these various pieces started to fall into place, I was fortunate enough to work with Robert Stegman, who actually was able to demonstrate motion within the collector channels, and we've got a number of videos of that, and is published in several books where you can watch the pulsatile motion of aqueous entering the aqueous veins, or entering the collector channels, that is, just distal to Schlemm's canal from when looking with gonioscopy. It's very, very striking.
Yeah.
Fascinating. And in addition, he's actually, he had a technique that allowed us, by just creating an equilibrium between intraocular pressure and episcleral venous pressure, by increasing episcleral venous pressure with a flange gonial lens, you could create an equilibrium situation where the aqueous was oscillating back and forth in the collector channels, and watch blood-stained aqueous moving out of the aqueous, out of Schlemm's canal into the collector channels. Stunning stuff, really wonderful.
But at that point, you still weren't actually measuring these pulse volumes.
No, you couldn't measure it. But the other thing was, he actually also showed aqueous flowing into the eye through little structures with a configuration similar to the valve-like structures I described histologically. You can watch the basically propagation of the aqueous into the aqueous, or into Schlemm's canal, and watch the blood mixing with the aqueous as it is injected into the canal with each pulse. So we have another piece of the puzzle there. So all these things start to come together, and but we had no ability really to image what was going on at the level of the meshwork. So we didn't have definitive evidence of this whole phenomenon.
Right. So then when did it get to the point where you could start to measure this?
Well, then we went into the laboratory and set up a laboratory system, which we used primate eyes, which were very fresh eyes, and also human eyes, and we're able to take the anterior segments, induce an ocular pulse that we controlled, and then with the OCT system, actually measure the or image the ocular pulsatile motion of the tissues, and then quantitate that motion with OCT. And in the laboratory, it's easier because you don't have motion. The OCT requires basically a tremendous amount of algorithms to get rid of extraneous motion in humans, because you've got bulk motion, you've got microsaccades, you've got many motions, and you've got whole body motion, you've got the ballistic head movements. All of these things have to be taken out in the living eye.
Right.
But in the ex vivo environment, you can really control it. So that allowed us to basically measure the motion of the trabecular meshwork, bulk motion of the meshwork.
Right. And which generation OCT was that?
That was with phase-based OCT.
Okay.
And should I'll talk.
Yeah. So that's the one that's in the nanometer resolution instead of micron resolution.
Right. And I'll explain that. What time-based or TD-OCT and SD-OCT are basically optically structurally defined, and they use standard optics, and the maximum resolution with standard optics is around 4 microns. That's a maximum that can be achieved with any of the commercially available devices, and it's a theoretical limit as well, 4 microns. And this is in contrast to phase.
That would be 4 times 10 to the minus 9.
That's 10 to the minus 6th.
10 to the minus 6th.
10 to the minus 6th. And I was very fortunate to work with Ricky Wang, who basically in about 2007 published some seminal papers, which were an entirely new conceptual framework of being able to tease out information about motion theoretically at the level of picometers. That's and the theoretical resolution limit is in the neighborhood of 50 to 60 picometers. That's the dimensions of the orbit of the electrons in a helium nucleus. It's astounding. Yeah. But the practical resolution, because of
pico is minus 12.
Because of the resolution with phase-based OCT is in the range of minus 10 to the minus 12, which pushes you into the range where you can get extremely high resolution. But I want to emphasize that it's not resolution, actually. It's sensitivity to motion.
Okay.
You can detect motion of tissues, and it's not a structural image that you achieve with this. So
we're talking now, so we're basically measuring with this device the equivalent of movement of electrons. Is that what you're saying? Or?
No, we're at the nanometer level.
Okay.
Yeah. So we're the best resolution with the system currently that's probably available is in the nature of about 20 nanometers.
Okay.
So that's a 10 to the minus 9.
Pretty darn good. It's still 1,000 times higher resolution than the SD-OCT.
Exactly. Yeah. And again, as we're talking about resolution of structure with SD-OCT, we're talking about basically sensitivity to motion,
right,
with phase-based OCT. So they're really different concepts, but what that allows you to do then is to tease out the motion at a very high level of resolution. And for that reason, the SD-OCT isn't able to easily, because of shadowing and vessel shadowing and the thickness and the scatter of the sclera, isn't able to resolve the trabecular meshwork motion at all. Well, it's quite limited, but with the phase-based OT, because of the far higher dynamic range, it can tease out the motion of the trabecular meshwork, and that's what we're achieving that's unique.
Got it.
And I'd like to also point out that what we're doing is we can, the same information that's achieved with SD-OCT, we're using phase to allow us to overlay an SD-OCT image. We lay the phase image over it so we can see where we are, and then we see the motion with the phase, and we see the structure at a much lower resolution, or I should say resolution with the SD-OCT. So we got structure and then phase overlaid on top of it, if that's reasonable.
Yeah, it's good.
Yeah. And so that's a phase-based issue, and that's why we're able to push this boundary to this level. It requires a great deal of work in terms of algorithms to, again, optimize and eliminate the motion. That's bulk motion, other motion than what you want. So,
right. So first you did that in vitro.
Ex vivo.
Ex vivo.
Yeah.
Okay.
And then
now you're.
And more recently, we've been able to then modify that to write the algorithms, and I'm very fortunate to work with Ricky Wang's lab and some of his postdocs who have written these algorithms that now allow us to tease out this information in vivo in living human beings, where we can actually watch the behavior of the tissues in real life.
Right. So I saw some of the videos. You had 5 human subjects where so far.
Yeah, we've done this now in over, I guess, about 12 subjects, and we can basically tease out the phase motion in all of them, but we're at about 80% success in terms of getting good quality images. But this technology is really in its infancy. The illumination capabilities, the camera speeds, all the algorithms can probably be improved by orders of magnitude still. Sort of like, it's a little bit like where MRI was when they first were able to see motion, and it proceeded, if you have an opportunity to read the history, is incredible. The advances that occurred as a result of all the various things that can be developed. That same thing is likely, I think, occur with a phase-based OCT. We're just really at the beginning.
Definitely. So I'm wondering with this then, have you looked at inter-test variability? So if you retest the same patient, and but as I was thinking of that, it also dawned on me, if you get a different reading, it could be that their outflow is different that day.
Exactly.
So how can you even confirm it?
Yeah, it's a real-time issue.
Yeah.
That's right. Yeah. Well, there are many questions that that first of all, this immediately starts requiring you to ask. First of all, how does it vary by location around the limbus? How does it vary from minute to minute? How does it vary with the pulse rate? As you say, what's the measurement variability? But of course, because it's a real-time living situation, it's a changing second by second, instantaneous changes. It's going to be varying from minute to minute. So, and second to second. In fact, every pulse, ocular pulse, you've got that issue. Mm-hmm.
So, would you be able to imply from this that areas in the eye where you're seeing bigger pulsatile flow, that the collector systems are working better in that area, and you might consider clinically to target that for treatments?
Yeah, we actually have, and this is published work, by the way, the phase-based information. We have actually 10 patients where we're able to show simultaneous pulse peaks and the tissue motion peaks, and basically they're highly synchronous. It's something like an order of 0.0009 or something in this range. Very highly significant correlation between pulse and the trabecular meshwork motion, basically the peaks. But in some ways, an even more interesting thing, which we recently published, is we had a patient with an iris cyst, which closed the angle on one side, but the angle was open on the other. And on the side with the closed angle, there is no pulsatile motion. On the side with the open angle, very easily measurable pulsatile motion with all the pulse amplitudes and velocities that you would anticipate. So we have good evidence that where there's an absence of flow, there's no motion, and with normal flow, we have motion. So that, I think, to some extent answers your question. But we also have so far just been working in normals because we feel we need to establish a database of normals and what their amplitudes are before we should begin to try and understand what's going on in glaucoma. One of the major problems with this is that there's likely to be quite a spectrum in glaucoma, and patients who are on medications that are perhaps enhancing their outflow might look fairly normal. But so there's that issue. We also have the issue of the question about what happens with laser procedures before and after. What happens with if somebody's had a surgery, what would happen? What happens in people who've had stents in areas adjacent to the stents? There are numerous questions.
It's really incredible. Just something else that's dawning on me. I'm sure you've looked at this too. Is there any sort of like Eisenberg uncertainty principle thing in that the act of trying to measure this, you're altering the flow, and that's
that's a really good question. I mean, just from the standpoint that I guess every patient perhaps has a possible risk of a white coat syndrome, which with every aspect of our measurements, we have an issue. But aside from that, the wonderful thing about this is it's non-contact and it's non-invasive. So it's a standoff distance from the eye. So to the extent that you're doing something like equivalent to a slit lamp examination, there's probably it doesn't have the issue of the Heisenberg uncertainty principle from that standpoint. You're not interfering with the system directly. But some other things I might cover is that if we got this figured out well, and it's going to require a great deal of optimization, but it's quite possible as we look forward, and I guess I'm trying to envision, say I'm a bit of a dreamer, but that we'll have a small portable device that can be probably used as a screening tool, and quite conceivably it could be used to screen people to determine whether they have normal motion or not. And very early in the disease process, you might be able to identify people without normal motion, and before they start getting into major problems with pressure, identify those people. Another aspect is that, as we've talked about many times, the intraocular pressure measurements we take are not a very effective tool to understand what's going on in terms of pressures. And for instance, diurnal pressure changes, the fact that we have patients looking straight ahead without any motion when we check their pressures, and the fact that pressures vary as much as 10 millimeters with blinking, the ocular pulse, which we don't really characterize at all, and yet it's a constant variable. And then the diurnal changes, which are about often 5 to 10 millimeters. We don't characterize any of that with our current techniques,
Right.
but this apparatus, this beautiful apparatus in our eye that's maintaining homeostasis, if in fact we could characterize that well, we might be able to get a much better sense of what represents normal behavior and predict who's going to have problems with pressure at times when we're not measuring it.
Yeah.
So I think it has real potential there. Now, again, these are dreamers' concerns, but
We won't get anywhere if we don't dream.
no, this is you have to have the dream.
Big ideas.
Yeah, right. Yeah, and then of course. Where do you go? Basically, if you've got people with distal outflow system that's not working well, which we can characterize to some extent here, or the meshwork's not in motion, we could think in terms of perhaps having a far less satisfactory outcome with SLT or any of the laser procedures. We might want to move on more quickly to something else and spare them a long period of time when we're experimenting with different kinds of things and move directly to a more appropriate procedure. There's another aspect also with medications. First of all, adrenergics work in about 5 minutes, and I didn't mention this, but prostaglandins also have a time course. They work in about 20 to 30 minutes with a marked increase in pulsatile flow, and it might be we could bring patients in and put drops in their eyes, wait in the office and check.
We'll know what's going to work for them.
Yeah, before they leave the
That's
office,
amazing.
because when they come back at a later time, we're faced with people who, first of all, we don't know whether they're compliant or not. We might be dealing with a different time of the day. We're dealing with a different situation in any case. And we really, when we bring them back to that next visit, we don't know.
Right, but half an hour later, you have a lot more control over all those other factors.
Right, you've got a far more limited time frame. So the idea is you might be able to actually identify patients beforehand and eliminate those who aren't going to get a benefit. Many times when they come back, we think they've had a benefit, but it might be just regression to the mean. They end up in the patient with the meds for maybe the rest of their lives, or others who come back looking like they've had no benefit, but in fact may simply have not taken their meds or might have had a higher pressure that day. And so we can probably might be able to reduce the number of patients on inappropriate medications fairly dramatically. So this is another dream.
No, that's great. That really solves the everyday problem of glaucoma medical therapy, where for everyone you have to try them before you buy them.
Yeah, so that's right. Yeah,
you could go on for weeks or months adding or taking away drugs.
Right, without really not having a very clear picture.
Yeah, and not really reliable results if the pressure is down.
Another aspect of this, I've written this in a couple of publications, that we typically measure pressures about 3 to 4 times a year. And usually it's about a 1 second measurement or 2 seconds. And
yes, what percentage of their year is that pressure reading?
Right. So we do about 12 seconds out of 31 million seconds a year.
Yeah.
So, we don't really sample. Our samples are so limited.
So if you were comparing that to a political poll, like what's your accuracy of that poll of their intraocular pressure?
Exactly. Yeah. And the hope would be that if in fact we could get this system to work well and to characterize the behavior of the outflow system and its ability to maintain homeostasis, normal motion, we might be able to totally alter our thinking about how to manage the disease process. And, when to go on to laser, when to consider surgery, where to go with surgery, where to place the stents. All of these things have some potential, at least, for being considered.
So it sounds like this technology has diagnostic advantages and treatment implications, be it medical, laser, or surgery. So
diagnostic.
Sounds like sounds incredible.
Sort of like I had a family member with a cardiovascular issue recently with a valve issue. Every aspect of her care was dealt with echocardiography, which is very similar to this, where we can actually watch the tissues in motion from the initial diagnosis to decisions to initiate treatment,
Right.
to escalate treatment, to decisions about whether to move on to surgery, the type of surgery to use, and basically even the approach to surgery, where to come in for surgery, are all determined by the echocardiogram. And
Right.
this is quite a similar conceptual framework. So
That's right. Now you could do angiography and wall motion studies and
exactly,
open up a coronary artery with a stent and see the flow improve and see the wall motion improve. And
yeah.
this is sort of doing a similar thing.
Right, and watch the motion through the valves, watch the valves themselves.
Yeah.
There's another piece of this that we've developed is it's this technique can see motion, but it doesn't see structure very well. So what we did also in the laboratory was to take eyes and basically take segments of eyes and lay them out in front of the optical, the OCT system, and then basically direct the beam through the trabecular meshwork, where there's a very short path width, and then we introduce cannulate Schlemm's canal and then induce pressure gradients into the canal, and we can watch in real time the canal dilate, and we can watch when the canal dilates, the collector channel ostia change shape. And it turns out that there are basically hinged collagen flaps or leaflets at the collector channel entrances. Essentially, it looks like all of them. And there are structures spanning between the trabecular meshwork and these collector channel entrances. So every time the meshwork moves, these structures move as well. So the whole apparatus is hinged, and the motion is clearly synchronous. The advantage of using this system going through the trabecular meshwork is that we can see this motion in great detail, and by dilating the canal, we can really get an idea of relationships between the trabecular meshwork, Schlemm's canal, the structure spanning the canal, the collector channel entrances, and also the intrascleral collector channels, which run often parallel to Schlemm's canal. So we've got this whole apparatus that we can watch in great detail, and then correlate that with what we're seeing with phase OCT with the motion. So what I'm describing going across the trabecular meshwork is SDOCT, which has high resolution of structure, and we can use that in this environment. But another aspect of this is the transcameral probes can be developed. I think, in fact, there's some actually trying to be developed right now that will work by both structural OCT and phase OCT that may give us fantastically high resolution for intracameral study of the outflow channels and where to place items, how the whole system's working, basically the information necessary for probably optimizing our MIGS procedures. So that's another piece of the puzzle. Is very exciting.
Yeah, that's really neat. Hey, you should maybe get together with Mike Berlin and see what happens in patients with ELT and what happens with the outflow there.
Absolutely, yeah. Right, yeah. I'm exploring with some other modalities as well. We've got the ability to look at that. So
great,
fun stuff.
Yeah, well, it seems like a good place to wrap things up.
Sounds right.
Thanks for being on the show. Take care.
That's our show for today. Thanks for your patience as I slowly post new episodes, including a talk about the new glaucoma drug, Ropressa. Please rate the show on iTunes, as this is the best way for other people to find the show. You can subscribe using iTunes, Pocket Casts, Google Play, Stitcher, or wherever fine podcasts are found, and new episodes will appear in your podcast player as they come out. Please tell your friends and colleagues about the show. Drop me a line at podcast@iguy.org with your comments. Visit wholelotofrob.com, westcoastglaucoma.com, or follow me on Twitter at Rob Schertzer. Links to all of these are in the show notes. Remember to keep fighting glaucoma by early detection so that nobody loses vision from this group of diseases.